Okay, we are going to discuss chapter 15, and I am not going to go over some of the non-pharmacological ways to control pain that are present in the book. In fact, I'm just going to focus on basically epidurals and some of the drugs that are used when discussing pain management. The other thing is, before we go on with this, we're at the end of the slides. We're going to go over a handout that you do have access to under week 2 resources. It's an epidural handout, and it describes all the steps and nursing care that's involved while giving an epidural. Make sure you print that off before we go on, because we're going to discuss it at the end and discuss some key points that you need to know. Okay, labor and delivery and pain management. First of all, when we use systemic drugs, and usually we will do this by IV push or by IM, the goal is to provide maximum analgesic with minimal risk for mother and fetus. Remember, when we give drugs during pregnancy, a lot of it can pass on to the fetus. So essentially, we have 2 patients we deal with when we give medications to a pregnant woman. All systemic drugs used for pain relief crosses the placental barrier by diffusion. Fetal liver enzymes and renal system is inadequate to metabolize analgesic agents, so high doses remain active in fetal circulation for a long time, which means that when we give drugs to someone in labor for pain, even though she may start feeling the effects off after a little while, they remain in the fetus for longer because they're not able to get rid of it as quickly or metabolize it because of, again, the liver and the renal system being immature. The next thing we're going to discuss is the blood-brain barrier. It is more permeable at the time of birth for the fetus. And remember what that blood-brain barrier is. The main function of it is to protect the brain from changes in the levels of blood or ions, amino acids, and such. And what it is that those blood capillaries are very, very tightly woven and sealed together at tight junctions. And these junctions, what they do is they prevent water-soluble substances from going into the brain. So when you deal with a fetus, a lot of things that would normally be protected as an adult from getting into our brain, they are more permeable too. So they are more likely to pass into the brain and the central and our CSF circulation. The one thing that does pass, whether it be for an adult or a child, is fat-soluble molecules that does pass into the blood-brain barrier. And look what is considered fat-soluble. I don't know if this was reviewed in MedSearch 2, but some of the things is oxygen, anesthetics, and alcohol. Alcohol does pass through the blood-brain barrier. That's why we feel the effects. But one of the advantages also of the blood-brain barrier is why we don't commonly see infections of the brain. You know, we don't see, it's not common to get that because of that blood-brain barrier. It's one of our own protective mechanisms. The problem with it, though, when we use drugs that treat certain things that are water-solubles, for instance, the AIDS virus, that drug that's used, that they use to help in the treatment of AIDS or to help prevent it from getting worse, is that it's water-soluble. So it won't go past the blood-brain barrier on an adult. So I thought that'd be interesting to mention. But that's one of the things we worry about when we give drugs while a woman's in labor, that the drugs that could pass through even more so in a fetus. They have an immature blood-brain barrier as it is, and it's even more so at the time of birth. So one of the things we got to worry about with analgesics is that if it's given too early, it may prolong labor. And IV meds, and we discussed this in the Skills Hub, should be given during the contraction. So you want to give it at the beginning. So by the time it ends, because all narcotics are pushed slowly, so more of it is going to mom's circulation when she's having the contraction, so there's less going right into the placenta during the resting phase. Also, we should never give meds between 1 to 2 hours of delivery, and the reason being is if the fetus tends to hold on to it longer, you're going to have a fetus born with respiratory depression if you're going to give it 1 to 2 hours of delivery. And the problem with that is they're going to be limp, which is going to affect their natural ability to retain heat, because when they flex up to themselves, that's one reason why we swaddle them. It helps them to retain their body heat. And also, it affects their ability to adjust from fetal to newborn respiration, or their respiratory system, breathing room air. If they're depressed, it's gonna slow down that process. So it puts them at risk for many different things. So we don't want to provide narcotics if we know they're going to be delivering within 1 to 2 hours. The first drug I want to review is Demerol. The one thing I do want to mention about Demerol is that it is never a first-line pain drug. The only time we would really use this drug is if someone may have an allergy to one of our other common drugs, such as morphine or any type of synthetic form, or Stadol if they weren't a candidate for Stadol. But this isn't, and I'll go over why later. First of all, it's a narcotic agonist, and remember, in pharmacology, you learned the difference between agonist and antagonist, and it makes a difference on some of the side effects you're going to see, which we'll see in a minute. We can give it by slow push. It can be given IM, even though we really don't give it that often now, IM, and at least labor and delivery. Usually we'll give it over a push. And then our onset, when we do give it by IV, is 30 seconds, and we will actually start seeing it will cross the placenta and appear in the fetus in 1 to 2 minutes after an IV dose. Well, you're probably wondering, how can you see it in the fetus? Remember when we discussed variability in our skills lab? One of the things that could make it become minimal or affected, and that's the central nervous system. That is what you're seeing when you're kind of looking at variability. It's how the nervous system is kind of responding. Is narcotics depress it, right? So we may see a change in the variability on a strip after giving a narcotic agonist to someone in labor, and we'll see it in the fetal strip. We may see that change. Some of the side effects we see, and this is where I'm saying what agonists, when we deal with narcotic agonists, it's a depressant in a way. So some of those adverse concerns that we see is respiratory depression, bradycardia, severe hypertension. And those are things we're going to worry about, especially when we're dealing with severe hypertension, because again, remember, we're going to not only deal with the fetus getting some of this drug, but mom's hypertension is going to affect the perfusion of the placenta. Now, other side effects we commonly see with this drug is nausea and vomiting. That's one of the other reasons why we try not to use this. It's one of those common side effects that we see. Now, what I had mentioned earlier with the CNS, we're going to see some variability changes. That's how we're going to see it in the fetus in 1 to 2 minutes. They can have, in fact, moderate depression. And the one thing with any narcotic is it's time and dose dependent. That's the rule when we use it during labor. What that means is how soon we give it in labor and how much. Some of the things we're going to see again in a newborn and its effect on the CNS system, especially if it's given too close to birth, is that we're going to see the respiratory depression. They're going to have poor feeding because they're lethargic from the drug. And again, hypothermia, because if they're not flexed and they're limp, they're not helping to retain their own body heat. The other thing we're concerned about, well, of course, we can always give Narcan. Okay, if we have to, naloxone should be available when you use this. In fact, what we can do is if a woman's in labor, okay, this is important to remember, key thing, write this down, is that if a woman's in labor and we don't expect that she was going to deliver for 4 hours, and we give her maybe some Demerol, but we realize, oh my gosh, now she's going to deliver a half hour, 40 minutes later, or not so much that, but we see changes in the strip. We gave it, there's like no variability. The baby's starting to become bradycardic, and we want to reverse, we want to take that drug away from the fetus. We can give Narcan to the mother, and it will reverse it in the fetus in utero. What you have to remember then is mom's pain in labor is going to return because you're also removing or reversing the drug in her also. So that is one of the things we can manage that situation. If the baby's going to be born, we're concerned about the strip, we think it's not looking well and we need to reverse it now, what we can do, and the baby's not ready to be born, then we can provide Narcan to mom to help the fetus, but then mom's pain is going to return with that. That's what you have to plan for as a nurse, because it will remove it from her also. Now, getting back again to Demerol, one of the things we worry about it is the reason it's not first line is the drug itself. Yes, it does manage pain and may be helpful. The problem is when it breaks down, any drug that breaks down has a metabolite that we get rid of. That's what we excrete. We use the active part, like it does for pain relief, and it has a byproduct that we have to get rid of. The problem is Demerol's or Meprodine's metabolite is called normepridine. It has a very long half-life. That byproduct can be around for 15 to 20 hours or even longer in patients who are elderly or have impaired renal function, because they're not excreting that metabolite quick enough. Now, this normepridine, if you get toxic effects from it and you build up on it, it has possible side effects of it, including tremors, seizures. It's a cerebral irritant. But the problem is we can't reverse those effects. If someone has too much of that metabolite, Narcan does not reverse it. No antagonist can reverse it. So we have to be very judicious in who we give Demerol to. And even though we have these healthy pregnant women, most of the time, in general, with that drug, the Agency for Healthcare Research and Quality Acute Pain recommend that we only give it for a very short course if we're going to use this drug, and we give it to healthy people under age 65, and only if they have experienced adverse reactions to morphine or hydromorphone. They also recommend, the American Pain Society recommend that we limit Mepridine to a 48-hour pain limit and not to exceed 600 milligrams in 24 hours. So I just want to stress that, because remember, your fetus has an immature renal system. So if we're going to give something like Demerol to a pregnant woman, she may be okay with it, but what is the effect on the fetus? Because we don't know if we have an impaired fetus in this situation. So that's why you have to be very careful in when we give Demerol. It's something that this is why we worry about this drug. Okay. Next thing is Stadol. Now, with Stadol, now we're dealing with an agonist-antagonist. It's a mix. So the side effects go from both ends. Okay, here it is on the slide. We can have an onset by IV in just 1 to 2 minutes, and it can last for 2 to 4 hours on the Stadol. And so remember when we saw the agonist, the side effects, it was being hypotensive and such, but when we have an agonist and antagonist in the mix, the antagonist is the opposite. Our system's going up, so instead we're seeing palpitations, we're seeing clamminess, we're seeing sweating, we're stimulating things instead of depressing things like you would with an agonist. So in an agonist-antagonist drug, narcotic, you may get either side. So the other concern is when you're dealing with someone who is a narcotic addicted person, we're not going to give Stadol because they're going to go through withdrawal. They are addicted specifically to an agonist, and that's the type of drug we have to give, because even though we're addressing their pain, they're going to go through withdrawal symptom, and we don't need that added stress on the body for someone who's going in labor, because it may impact the fetus. So even though drugs are not the best thing, we don't need the added problems of withdrawal also. So we would not give Stadol to someone who's narcotic addicted. And it's really reviewed and detailed if you're taking special topics also under one of the chapters there, our special needs chapter. Okay, so when we do systemic drugs, what's our nursing process? Well, first we got to have our patient goals for pain. What is it that they're saying? You know, my pain will be comfortable at 3 out of 10 or a 4 out of 10. And as you know, that's one of JCAHO's rules. Now, it's not giving pain relief, but what the patient guidelines are for pain relief. And of course, you know, when it comes to this area, it's not always possible to get 100% pain relief when you're in labor. But we want to, at least if we can't reach the goals, write down any type of nonverbal behavior, how they're coping with the pain. Remember cultural consideration. Someone may be in severe pain, but in their culture they tend to be stoic, maybe a flat affect, so they may not actually show it. We also got to get those baseline vital signs. We also got to know labor progression, because if it's going to slow labor, especially through the active phase, remember we want to go 1 centimeter at least per hour, or 1.2 for multipara, 1 for nullipara. And the absolute biggest thing, what we're going to review for the 20-minute strip before we give a dose. Remember this, whenever you do anything, provide any drug, any type of procedure to a woman in labor, you got to look at her past 20 minutes of fetal strip. Okay, because that's what you're going to compare changes to see that there's a change. You need a baseline. So we're going to look at the past 20 minutes before we give the drug to see what happens afterwards. We're also going to screen if they have a history of any drug-to-drug interactions, see if they have a history of drug addiction. We got to worry about that also. And some of the nursing diagnoses, of course, is pain, acute pain, more likely, fear, anxiety. Those are ones that we can use. And in our plan, what we're looking for is a decrease in pain on a 1 to 10 scale. So you'll say client report will rate pain less than 4 on a scale of 1 to 10. You have to be very objective when you write your nursing goals. And our other big concern is that the client and the fetus, because there's a risk for fetal injury when you're using narcotics, will display no severe side effects of the drug. What are some of our interventions? Well, we can offer appropriate analgesic based on the stage and phase of labor, because, again, we're not going to give narcotics if we expect that she's going to deliver this baby in a half hour. We have to use safety measures about checking drug compatibility, especially if we're running a lot of drugs through an IV. We got to make sure we have our antidote at bedside. Continue to monitor the fetal strip and monitor urine output. Because if we tend to get urine retention with narcotics, what is that going to do? We discussed that in an earlier chapter. It's going to impede fetal descent. The other thing we're worried about, if something's going wrong that impacts urine output, then we're not releasing the drug from the body if it's released through the renal system. Okay? So those are 2 reasons why we got to watch urine output. Demerol, we're going to check the respirations. We're going to make sure, of course, get those baseline respirations for giving the drug. Got to make sure they're more than 12. We got to watch bed rails. We're going to push slowly during a contraction. And for Stadol, we're going to observe for, again, hopefully they were honest with us, and if they were addicted to narcotics, we would see withdrawal. In our evaluation, we're hoping vital signs remain stable, and we have effective pain relief. Okay. Let's look at regional analgesia and anesthetics. And this is more of our spinal and epidural. It's regional. It's less likely compared to systemic to pass through the placenta. Well, first we're going to discuss the pudendal block. It's an injection of local anesthesia into the pudendal nerve. They use this a lot for the last. Remember, we know the difference between stage and phase. So the latter part of first stage, so that would be during the transition phase, during the second stage of delivery and repair. So that's if they know they're going to do an episiotomy, or if someone had a bad tear, they may use this. And to help, a lot of times in natural labor, women will complain of a terrible burning sensation, the stretching of the tissue as the baby moves down the canal. So this will help prevent that. So it does relieve that pain of perineal distension, but it does not relieve the pain of contraction, so they will feel that. The benefits of it, it has minimal effects on mother and fetus. It will not slow down labor. It does not cause maternal hypotension and does not alter maternal vital signs or fetal heart rate. Now, in an epidural, it is a form of regional anesthesia. Some of the ones we could use, there are different drugs that they use. They may use morphine. Fentanyl is a common one used, Stadol. Very little crosses to the fetus. And it's administered by catheter, and remember from a prior video we saw on skills, it could be in L3, L4, or even L5. And there's a very low incidence of headaches, and we'll talk about headaches later, spinal headaches. What is the contraindications for it? And before we go into that, I just want to mention when they do give the epidural, it does require a test dose. When they put in the epidural, okay, what they do is they have to give a test dose to determine if the blood vessel or the dura was punctured during the catheter. So when they give the test dose, they'll ask, do you feel anything? And if she complains of rapid tingling to the face, dizziness, sensory block, because now it's hitting the upper part of the body, right? And what else is affected by that? The lungs and breathing. So that's what they're checking for, and they know that they went in too far. But even though that could happen, who could not get it in contraindications? Anyone who's had a severe systemic infection, anyone with coagulation defects, because you are puncturing in, so if they have problems clotting, you could have bleeding and leaking through the hole you just made. And uncorrected hypovolemia. If someone has low circulating volume and we did not correct it, we will see a side effect of epidurals is hypertension. So we don't need someone who's vulnerable to begin with of being hypotensive and adding to the situation. For the same reason, we're going to affect placental perfusion and make the situation worse. If they have an infection at the area of insertion, because then you're going to introduce that infection into the subdural area. That's what you're going to do if you're going to go through that. If they have any allergies to the drug you're using, and also fetal condition. If we have a severely compromised fetus, we're not going to perform procedures that could make the situation worse. And the reason being, again, the possible side effect of hypertension could ultimately affect a fetus. When we do an epidural anesthesia, there's always an RN in constant attendance. They try to give it when active labor is established and the fetus engaged. And the problem is it can result in decreased ability to bear down and push. So usually during that time when you're ready to push, like we talked before, when they have that, we have to look at the monitor, see when the contractions are coming on, work with them, and tell her to try to push. So we're not wearing her out and prolonging labor. One of the things we worry about with it is bladder distension. We're going to do frequent 1-hour bladder checks, even though they usually are put on catheters when they use epidurals frequently, and that's because the risk of, again, bladder distension and keeping an eye sometimes on output. We base on facility policy. And that's, again, because of fetal descent. And also because, of course, the mother will not be able to get up once she has an epidural and be able to use the toilet. Catheter migration may occur after proper placement. That means that tingling and such may come on. It could migrate out or it could migrate forward. That's why we do a really good job with taping to hopefully hope that doesn't happen. Now, this is interesting. It is not uncommon that we see maternal fever after epidurals. They really don't know the exact cause of it. So if someone's on an epidural and running a fever, what we don't do is we look for other signs of things going on. We don't just automatically provide antibiotics. But what we do have to do is we got to try to lower that fever because, again, that will make your fetus tachycardic. So even though it's a side effect, we have to give something to help bring that down. The other thing we worry about is, especially if we give morphine, there's a risk of delayed respiration depression that can be up to 24 hours after it, and that's why commonly in a postpartum unit, if you say Duramorph precautions, that is someone that received morphine or a form of morphine by epidural, and they're at risk for possible delayed respiratory depression. So they still have to be monitored, even though they stop the epidural, and it's still it's within the 24 hours after. The most common complication we worry about epidurals is the maternal hypertension, and if they have a really good blood or circulating volume, which we use with hydration, it decreases that risk. So what we tend to do for an epidural is we'll give 1 to 2 liters of lactate ringers. We'll do a quick bolus of both of those to help expand the volume before we actually perform this procedure. However, after the procedure, if we do become hypotensive, then let's do our intrauterine resuscitation. We should have this memorized by now. We went over it several times during lab. Turn to left side, provide O2 at 8 to 10 liters, notify the MD. Now, suppose we can't fix it. Suppose, despite the fact that we did that, we bolused her, we give it, and we're still not bringing up the blood pressure. We can give IV ephedrine, that's what we're going to give, and we can give it to 5 to 10 increments and to cause some vasoconstriction and help raise the blood pressure. So the base thing is, if we're worried about blood pressure, then what are we going to get for baseline? Of course, we're going to get the baseline vital signs. What is her blood pressure, so we know what we're measuring it against? The other thing, of course, is that fetal heart rate, and how long are we going to have that strip? At least 20 minutes we're going to look at before starting this procedure. Her correct position, usually they're sit up, and the big thing is rounding out the spine. They can do it in bed also, but the key is so they can get between the spine. The woman has to round out her back, so you're going to help her round out that back, and sometimes it's not so easy when you have a large stomach from a pregnancy in front of you. And then if she's having a contraction, it's holding her still while they're doing this procedure. After the procedure, we're going to assess the blood pressure and fetal heart rate every 5 minutes for the first 15 minutes, because if we're going to get a significant response right away, that's where we're going to see it. After that, guidelines recommend 15 to 30, but that will be based on the institutional policy, how often. Most will do it every 15. They'll go on the conservative side. Other side effects, and it's based on the drug that's being pushed through the epidural. They may have nausea and vomiting. Remember, we went back. Demerol had common nausea and vomiting. Several of these narcotics do. And pruritus, so we may be giving an antipruritic to help if they suddenly develop itching. Now, with spinal, we are injecting right into the spinal fluid between the dura and the cord. Now, this may be done when the fetal head is on the perineum or for a cesarean birth. Yes, it gives excellent muscular relaxation, but because of that, they are a risk then for postpartum hemorrhage, because we relax those muscles, because the uterus is a muscle. Has no effect on their level of consciousness, but again, high incidence of maternal hypertension and maternal hypoxia. The other problem we're worried about is this uses a larger needle, because that dura is very thick. They got to use a larger needle and longer needle to get into that area. Now, the contraindications and precautions are similar to the epidural, so it would be if you have any coagulation defects, uncorrected hypovolemia, allergies, infection to the area. Those are all the same precautions about worrying about hypertension. Now, with this, we have to monitor the vital signs and fetal heart rate every 5 minutes instead of just, for the first 15 minutes. So we're watching this a lot more carefully, and we have to avoid sudden movement, because that can lead to hypotension. Now, the most common complication related to this is a headache, and that's leakage of spinal fluid at the puncture site. And I'm going to explain how that happens. What happens is, when we look at our blood-brain barrier, okay, that's that network, and within that, when we look at our cerebral spinal fluid in our brain, the brain is buoyant within the on top of the spine, and it's just being buoyant within. It's like a fetus within the placenta in the amniotic fluid. Well, within the cerebral spinal fluid is the brain. It's being nice and buoyant. It's being held up there with fluid around. Then what happens is, if you have a leak, you're taking down the pressure. So the brain is sort of almost relaxing or falling on into an area with pressure, and that's where you're getting your headache from. It's leaking like a leaky garden hose. What happens? You decrease pressure. You don't have the same pressure when you have a leaky garden hose. So the pressure is down some, and that contributes to the headache. So some of the ways to bring back that circulating cerebral spinal fluid that we need, what they try to do for prevention is you try to use the smallest needle possible, and if we keep them well hydrated, and flat in bed, because pressure is going to be more with sitting up against the hole that was made. Lying flat will decrease the pressure. And if it does happen, it will begin on the second day. It can last several days to a week. Now, how are we going to treat it? Bed rest. We don't want the brain, again, let it rest. Don't let the pressure cause it to, again, relax, and the pressure down the spinal column and leaking out. We need to lie flat and be on bed rest. Increase fluid, so cerebral spinal fluid will keep trying to make it to replace what continues to leak. And analgesics for pain. Now, if it's very severe, if we can't conservatively treat it, or if it's so severe, no one can wait through several days of it naturally trying to heal itself, we can use a blood patch. And basically what they do is they do a phlebotomy technique, and it's under sterile conditions. So it's usually done in an operating room where it's under sterile, because they're putting this into a sterile area. They remove some blood, and they inject it into the site that the original spinal was done. And what do you think of blood if you draw blood? Well, in there is our natural circulating fibrin, which is like a seal. So it takes the natural circulating fibrin that we have and have it make its own Band-Aid in there and seal it up. It's almost like the Dutch boy putting his finger in the hole of the dam, if you ever heard that story from many years ago, to prevent it from leaking and let it naturally fill up the hole with our own natural body body stuff, our own fibrin, instead of putting in something unnatural. So the last thing is general anesthesia. That's only time we really give that is if someone is in an emergent situation. We don't have time to worry about starting an epidural or spinal, or they're not a candidate. Suppose they do have that allergy to, or that infection to the insertion site, or some type of coagulation defects. And again, under emergency conditions. One of our big concerns, which is one of the number one causes of death of pregnant women, is maternal aspiration. So to help prevent that, we want to maintain, that's one of the reasons why we maintain an NPO coming in. Just, they have a slow GI system in case we have an emergency situation. We don't want any food or fluids there. We're going to raise our gastric pH. We're going to provide, just like a lot of surgical patients, Bicitra, Zantac, Tagamet, and we're going to reduce potential secretions and speed up gastric emptying with Reglan. Our big concern is uterine relaxation with this drug, like with the spinal. They're at risk for postpartum hemorrhage. And the other way we can help with the risk of respiratory depression in the newborn is between the time we give anesthesia to the time we cord clamp, that will keep maybe some of that drug out of the fetal circulation. And the worst thing is, if a fetus is born completely limp under the influence, we can give Narcan to the newborn after it's born. Local anesthesia, that's if after birth we want to repair a episiotomy, a laceration. There's a slight burning. It's the same thing they give whether you get stitches anywhere, same area. So let's go back to regional. What are some of the things we got to worry about? We're going to assess labor before giving an epidural. We got to worry about those vital signs again. We're going to have to worry about their knowledge about what's being done, because this is a separate consent if we're going to do an epidural spinal. So they have to have informed consent about what's going on. We have to know where they are in labor, review fetal status, which means we're getting a strip, and make sure there's no contraindications to the procedure. In analysis, we got to worry about pain. Impaired physical mobility is one, because once they have that, they can't feel their legs. We have to worry about that. Make sure that they're not in a position that's affecting circulation. And again, make sure they have the knowledge and know what's going on, because I've had a couple patients in the older days, we used to have laboring women who want to go out and have a cigarette, and when hospitals were not smoke-free, and they didn't realize once they got the epidural they couldn't be wheeled out to have a cigarette. So they have to be aware that once they get that, they are not out of that bed. That is where they're staying. And also the plan that they will verbalize pain relief. They will maintain normal vital signs because our concern is hypertension, and the client and fetus will remain safe. Some of our interventions, again, hydration. We're going to bolus 1 to 2 liters. Positioning. We got to position them, monitor progress, and make sure you have your resuscitation available. Oxygen, ephedrine, and antihistamine should be readily available for you to do this procedure, and make sure you assess the bladder regularly. So things we're going to look at in our evaluation is that they have good blood pressure, adequate urinary output, fetal heart rate is reassuring. We have effectiveness of the pain management, and they do, after we're done with everything, have return of motor abilities. That's one of the things we check, and they're always walked first time to the bathroom with the nurse because they have the feeling that the floor is coming up out of them. They're at risk for falls. Okay, and there is usually now a QA if a woman wants an epidural. Most of the QA is that she gets it within 30 minutes. Okay, what I want you to do now is I'm going to keep this on, and we're just going to discuss that handout. I just want to pull up some key points. It's your epidural handout. It's some of the guidelines that is recommended by for hospitals. And in your first section, it discusses about the action before epidural, where we have to make sure there's documented informed consent. If there's any type of contraindications, we get our baseline blood pressure pulse. We have to make sure we have a reassuring fetal heart rate, and make sure she voids before the procedure. We administer the IV fluid bolus bag. It could be 500 to 1,000. Sometimes they may even do more. We put her in a side-lying position to prepare for it, or she'll sit up and round out her back. We're going to support her throughout it, and always an epidural is put on its own pump. It's a specific pump that's used to make sure that the proper hourly rate is done. And again, we note those blood pressure and pulse changes every 5 minutes for the first 15 minutes afterwards. And in the test dosage, what we're looking for is what they use in the test dosage is epinephrine. When we look at the blood pressure after, the one we're worried about is a systolic drop below 90, and that's the key. Even when you discuss shock, when you talk about med-surg, when it comes to organ perfusion, it's the systolic, and we want at least 90, okay? That's the number. So we're worried if it does drop below 90, because we absolutely know there is no uterine blood flow to nourish the placenta if we drop below a 90 systolic. Now, sometimes you may feel warm and tingling with the initial bolus. That's normal. And one of the ways to help to control that potential for maternal hypertension is we want to make sure that uterus is not lying flat or straight back on the aorta. So we're going to displace it with a wedge under the hip to help that. Because sometimes if you put her completely on one side for a while, you're going to have trouble picking up a strip on the monitor. But one thing you can do is use like a pillow or wedge to just put a slight turn on her position. And we want to turn her approximately every hour. This allows the drug to really go to both sides, and also with not putting pressure just on one side too. We got to make sure that we evaluate her bladder every 30 minutes. And we're also going to assess her level of anesthesia, make sure she's doing okay, and continue to monitor for those maternal complications. Remember what they are: urinary retention, nausea, vomiting, itching, and the other one we worry about is fever. So we got to watch for those, because we're going to have to address them with maybe some medication. And make sure you have your Narcan available. And we have to make sure that there's certain things we always document on, and this is not just with epidurals, it's with anything, and that's whenever we take vital signs. Every time we change her position, if we give oxygen, if we do changes in our IV rate, and any type of other supportive interventions that we do. We're also going to monitor how she progresses in labor. And then how we're going to respond. You do have in the handout actions to respond to complications. Our concern is if the systolic blood pressure, once it drops below 190, is the minimal just to keep your own organs perfused, let alone a placenta. So we're going to have to address that because the fetus will be affected. And another concern is the long-term in decompensation is that we start getting fetal bradycardia or late decels as a result. And again, we do our famous interventions. Let's put her in a different position, provide oxygen, do bolus of fluids because we want to add that volume, help bring up that blood pressure, and if we have to, give vasopressors, which is ephedrine as needed. Again, in some facilities they do provide urinary catheterization during epidural. They can monitor output, make sure that the bladder is remaining empty. Some women may need something for pruritus, and a lot of times Benadryl will help with that. And urinary retention, high spinal. Let's see what else is important. Okay, let's go on to actions afterwards. When we remove the catheter, and nurses that are trained can remove the catheter that was put in. And basically what we got to do is we got to look at the tip. Usually it's blue, and you want to make sure you have an intact tip that it didn't break off and it's left in there, because you're going to have to let the anesthesiologist or CRNA know right away. Then we're going to keep asking her. We're going to assess for motor and sensory return, help her move her legs, see if she can do a plantar flexion, and eventually she'll be able to go to a sitting and then a standing, and that's usually when you'll walk her to the bathroom, have her take her first shower, but you as a nurse have to be with her during that first time up. If the neonate's affected, what we can do is provide Narcan. So we're going to watch the neonate after delivery too, see if there's any neurobehavioral changes. And that's it for that handout. Make sure you review it for the test. And also you can do your practice questions.